If you don't have a question, you must be asleep.
I hope not.
But you weren't. It was too interesting. No question. Thank you.
Can I ask the Deputy Circuit Judge, what's your opinion in formal settings, such as a coroner's inquest, of non-disclosure of the facts?
It's a long time since I did a coroner's inquest, and I don't remember what the rules are, and they've probably changed. The coroner is in charge, and it's up to the judgment of the coroner to ensure that relevant documents are disclosed. And of course, if there are any advocates appearing on behalf of the interested parties, then they would press the point as well. There's a horrible backlog with coroner's inquests.
Have you comment about that?
I prefer at this moment not, please.
Okay, that's perfectly all right.
As a tactics user, I'm Aruna Abhyankar. I have a comment to make if there is time for that. DATIC submission, once it happens, it is not managed similarly across all the trusts. For example, the person who is submitting the DATICs, whether they come to know about the progress of the DATICs and who is deciding and when, is not necessarily disclosed to the person who is raising the concern. What is your experience?
Well, first, if you launch a DATEX according to what you tick as a box, and DATEX, by the way, is a template provided to the trust, so the trust will say, as they did to me, no, it's a sealed system. I can show my trust what is missing now and what they have deleted and so on. So the problem is with the start, if you DATEX something, it goes to, I don't know, I had once a critical incident case which went to 52 different people. That means nobody deals with it, and it stops there. And if you start complaining, they push it up the ladder to the legal firm, and they deal with it on behalf of your trust. And the only feedback you get is nothing to do with your trust, it's all to do with the legal case.
I want to make a second observation, if I may.
No, just a minute, Dr. Aruba. Dr. Aruba is a paediatric surgeon from Wales, no doubt in trouble. We've got questions and answers coming online, and I don't have the faintest idea how to deal with them, so just 2 seconds. Can you deal with them? I don't do technology. I manage cardiology without it. Perhaps not very well.
Okay. Yeah. I think there are quite a few.
Sorry.
No, it's not visible on the screen. Can we put this on the screen over there? So there are quite a few interventions by people who want to. Rory Richard, can you help him?
Yes, I can read them out.
Okay.
So basically, one of the questions says from Sarah Jenkins, can you explain the term...
Stay together. You may have to answer.
Can you explain the term
Wim.
PPA for those of us in Scotland? Our processes are different, and it's helpful to understand the NHS England process. So that's one of the questions.
What's the question? Could you repeat it so they can hear it?
Can you explain the term PPA for those of us in Scotland?
Good.
Well, that's illegible, so can you make it legible?
I don't think he can.
Okay, you can't. Can you answer the question, boys?
No, I'm afraid not.
Oh, can anybody?
Yes.
All right. Sasha?
Yes. Can we have a microphone for... Yes, for Sasha. Thank you.
Girls will get priority in this organisation.
Yes, so the question was, what is the PPA? So PPA used to be NCAS. It is now known as PPA, which is the Practitioner Performance Advice. And essentially, any trust is supposed to approach the PPA prior to taking action against any doctor But what is interesting is that there never seems to be a follow-up from the PPA as to what the trust has actually done. So the PPA will issue instruction, the trust may or may not follow it, but they can tick the box to say that they have approached the PPA, and it's just what's meant to happen. And if a trust doesn't approach the PPA, then they can be found to be at foul of their policy, and that, of course, is a win for the doctor, and that can't happen. So.
Yeah, thank you very much. And there's another question which says, what is the role of the medical defense unions in these situations? Why do they not take on support of whistleblowers?
My answer, we have asked this question, and we don't actually know what the role of the MDU is. But I think when you go into it, it's too expensive to really support a whistleblower. And that's how they get involved just a little bit at the beginning. But as soon as they see a few noughts after the price, they somehow disappear. Does anybody else have a different view or a knowledgeable view to that?
Yeah, there are many.
VK?
No, Ifa.
Oh, sorry,
Ifa.
Ifa, you take it from Sasha.
Hi, my name is Ifat. The answer is that the vast majority of complaints or proceedings against doctors under MHPS, over 70% in trusts, are on the basis of conduct. And defence organisations, generally speaking, widely do not cover doctors on matters of conduct. They might cover doctors on matters of clinical negligence or capability.
Yeah, I've got another observation. I asked the BMA about this, and I said, you as a union, you must know about the number of cases coming through to you, because the members will tell you about them. Why don't you use the number against that trust? It could be 20 in a year or 30, and use them to defend them. And they say, we don't do that, we take one case at a time. So in a way, they are actually not doing their job properly, because if I am the defense and I see 20 consultants in one trust being treated like that, I say, hang on a second, what's happening here? Why are you doing this? And I put all the cases together rather than treat each case separately.
Hi, Salam.
Ush.
Yeah.
Obviously, I'm Shah Ali. I'm BMA counsel, trade unionist as well. One thing which I would always point out is trade unions generally deal with matters of employment and work, and whilst clinical issues historically have been clinical conduct, so trade unions don't deal with the clinical conduct. That's for the medical defence organisation, which you insure yourself with, can. Although the BMA does have BMA law and you can get services from them. But the medical defence organisations often deal with matters of clinical care. However, with most MHPS investigations, that happens within the trust, and that's when your trade union should be involved. If you have meetings, for example, with the case Sasha presented, and you're often not willingly a whistleblower, and you find yourself in that situation, you should walk out, speak to your trade union, get them to contact your employer. Don't dig a hole for yourself and participate and try and be nice with them, because they're not being nice with you.
Thank you. Ush, briefly.
Thank you.
Short version.
I
Stand
just
up.
wanted to say what Ifat has already
Please.
covered. So generally there's capability and conduct issues mixed in the MHPS. So MPS, MDU, they all would look after the clinical side of things. And then they say, right, thank you, we'll leave you with the BMA. They'll look after you because this is whistleblowing detriment. Thank you, goodbye. And then you're in the hands of BMA. And then we all know what happens after that.
Thank you, Ush. We have to stop the questions and answers now for the sake of time. Dr. Wim did not say his injury. His injury was bad, and I think I would have said if I'd been in his situation, but then we're all different. He fractured T8, T9, yes, and a bad injury. Somebody asked there.
Yes, it was, I don't know whether this microphone is working. Yes, okay.
Now, I am,
Yes,
sorry, have you
so-
finished? No, I don't want to interrupt you. Do you want-
So briefly, because the patient collapsed in a and was sitting up before I start anaesthetic, as you usually do, you ask what the most comfortable position is. There was a reclined position for the patient. I put the patient to sleep. Then I went to the head end at the trolley, and normally you should be able to gently put the patient in the right position by just lifting a corner of the sheet under the patient. I accidentally touched the locking system where there were no struts. The struts were there, but they were simply not working. So the patient fell backwards 1/2 meter. And so I put in a reflex movement, quickly my arms under the patient, and I got 50, 60 kilograms on my arms. There were only 2 centimeters literally between the board when it was flat and the metal frame underneath. So I had to keep the whole thing up as long as I could. Lucky enough, my assistant quickly came and pushed the corner of the trolley up, because otherwise my fingers would have been crushed. I banged my elbow on the metal frame. I have for life an ulnar injury on my left side, and I have an axonal C8 trauma in my spine, for which I needed emergency neurosurgery because my arm motoric function was going.
Thank you very much, Wim. I think it's really quite frightful.